Good evening, everybody. Wishing you all a very happy new year. And as I put it in the group, we have finished almost 1 year. I checked the date, it was 2nd of February when the first MDM was done. We have finished 80 cases, 80. And today's cases will be 5 more 85 cases, and we will be crossing our century very soon. We have our all usual experts, Rajan sir, Murli Mohan sir, Athol Well sir will be joining in a while. Mithun is our rheumatologist. Ritu Kulshrestha madam will be joining for a second case which has got histopathology, and we have got Dr. Aparna as a radiologist expert from CMC Vellore. And since we have 5 cases, with that brief introduction, we will be moving to the cases. I will just share my screen. Yeah, sir. Rajan sir?
Sujit, you're muted.
Sorry.
Yeah.
A 3-year-old lady, a homemaker in Mumbai, as you can see, never smoker, hypertension, and her past history of medical illnesses was just hysterectomy in 2010 and a hemorrhoid surgery 4 years ago. One other thing that she mentioned was that her son in 2018 developed multifocal motor neuropathy and received IVIG for that till 2022 and is now better. No family history of any lung disease.
What will be the age of his son, sir? Sorry to interrupt you that time.
Actually, I don't know that.
Okay.
But I would imagine
Younger
the son
one.
would be around in his, late 30s. Yeah, I think mid 30s to late 30s.
Yeah.
Yes, and I think the son was recently married. Yeah, but that doesn't tell us the age either. It could be anything. I think it's probably mid 30s.
Yes, sir.
His history of pneumonia in March 2020.
Your voice is
which he had
breaking in
recovered.
between.
Dry skin since childhood. And dry eyes. Since the past. And this was her blood count. Investigated.
Your voice is breaking, or I'm not able to hear. I'm not sure.
No, we are also not able to hear.
In fact, I think we've lost Sujit.
I think he's in airport or somewhere. Anyway, so
he has very clear slides, so you could choose to show the slides.
I will. So what we had seen is his HP panel was positive for alternaria and pigeon, and ANA, dsDNA, everything was negative on methylprednisolone for last 2 weeks, and now on 8 milligram per day. She is also on azathioprine 25 milligram per kilogram. Oh, sorry, 25 milligram per day. This is her pulmonary function test from April, August, and December. It's almost, FVC is almost status quo. DLCO is not done, but the last DLCO was 46.8% of predicted. The current 6-minute walk test distance is not available, but in April, she desaturated from 97 to 87%. And I will stop here and I will request Aparna to share her screen.
Are you able to see?
Yes.
Yeah.
So we actually have 4 CTs for her. So initial 2 CTs are These two are from 18th of March and 21st of March 2024. So let's just see the first one. I'm sorry. So the initial one, we see a lot of multifocal patchy areas of consolidation. And many areas, it's looking like small clusters of nodules which are conglomerating and forming consolidation. And they are definitely more in the lower lobes and forming more confluent, larger areas of consolidation. And there wasn't much of fibrosis at that time. This was on 18th of March. So the second CT that we have is on 21st of March. So just 3 days later. And in 3 days, there is definitely significant worsening is there between the two CTs. We can see that there's much more areas of consolidation developing. So I'm thinking that at this point, was this did she have anything acute happening at this March? Was
Yes.
this all any infection or like was it
Yeah, so
flu?
Aparna,
Yes, sir.
we diagnosed it as a in March and treated her only with antibiotics in March. She recovered from that pneumonia, and then she just they closed the chapter on everything in March as a
Okay.
community acquired pneumonia. And then the next I knew she was she was meeting me with these symptoms of cough, breathlessness, and wheeze for the last month.
So between the March and November, she was totally fine, sir.
And dry eyes
I think Rajan sir,
for the last 4 years.
you stop your video and just continue audio. Maybe we'll able to hear you.
Much as we regret missing your face, Suji.
So, but we don't have any X-rays or CTs in between to document that she had completely recovered radiologically. Sir is saying clinically she had recovered completely. So the next CT that we have is November 2024. So on this, now we are seeing already there is evidence of fibrosis. We are seeing a lot of areas of traction bronchiectasis, which is involving all the previously involved areas, especially lower lobes. Also, there is bronchiectasis, and there is again lot of areas of ground glass and consolidation, but they're more in the lower lobes again. And again, there are like small clusters of nodules and that consolidation. Even here, there are some clusters of nodules. So, is this a second infection that she's developing with some post-inflammatory because of the previous pneumonia? That is one question. Or is there some background ILD? And again, is it exacerbation or infection? So the next CT that we have is 1 month, 3 weeks later. So now all those consolidations that was there in November has actually nicely improved. So it was this dense before, and now we are seeing significant improvement, but there is significant worsening in the traction bronchiectasis. There's not yet any honeycombing, but definitely there is progression in the fibrosis. But all the consolidation, nodules, everything has significantly improved with some few patchy areas remaining. So is it really an ILD or is it a second infection that she has got, which is causing more fibrosis? Those are my thoughts. Other than this, she has some lymph nodes, which we are probably expecting because of all the things happening in the lungs. Pulmonary artery is not dilated, and she has a small hiatus hernia also.
Right. So, I mean, it was a rapidly, according to our CT radiologist, a rapidly progressive ILD. And they said to look for one of the myositis, and that's why we did the entire panel. Nothing came in positive. She had no symptoms of myositis. Her weight has been constant. And if you look at her lung function, that is low. She is desaturated. rating. You saw those PFTs, Asmita, you had
Yeah,
pulled them
yeah,
up?
I showed them. So she
It shows,
desaturated in April, yeah, to
correct.
87. Yeah.
So, I mean, with this scan, I mean, I was quite clear that we should give her an antifibrotic. That's what I felt. But I was just wondering on, do we just call this a rapidly progressive cryptogenic organizing pneumonia with fibrosis? Or what's our working diagnosis here? And I did, sputum was sent with difficulty because the last scan, Aparna, did she have any consolidation on the most recent one?
Not in the recent one. That is in the recent is 13th of December. In that there was no consolidation. 29th November she had a lot of consolidation, which resolved on 13th of
Okay.
December. Within 2 weeks actually it has resolved.
13 December, yeah. So they reported right upper lobe infeculitis on the December scan. Are you seeing
A
that on the
few
December scan? Can you
residual
pull up the scan?
minimal residual nodules are there in the right upper lobe and few other patchy areas,
But it's
but
resolved.
it's
Okay.
significantly improved. Yeah.
Right. And so I actually worried about tuberculosis, was wanting to, I didn't want to give her too much immunosuppression and all that, but that's resolved. I guess I mean, I thought we will have to give her antifibrotics, but I don't know if we have anything, how aggressive we should be with immunosuppression here. This is where I was a bit, and the rapidity with which everything was moving.
So between that, the March and between November when she was second time symptomatic, she was asymptomatic in that total time.
Yes, I would say largely
Okay.
asymptomatic or maybe distracted also because she was planning for her son's wedding.
Okay.
So she was completely immersed in all that. And, I think she said, I hardly felt any symptoms till the next episode in October.
Sujit, she had a lung function test done in August of 24, and
Right.
her FVC had actually dropped considerably from April when she had just recovered from the previous March
That's right.
infection. So was
That's
she
right.
symptomatic at that time? Because I mean, the FVC there is 1.08,
Correct.
but we don't have diffusion or 6-minute walk at that time.
To be honest, Murli, I asked her this question. In fact, the chest physician who was seeing her asked her for a lung function, but she says she was well. And I was just suspecting she's so engrossed with other things in life, but she insisted she was well till mid-November.
And in March, when she was diagnosed to have the pneumonia, did she have infective markers raised? Because it's been treated as an infection. So I think Dr. Aparna is asking an interesting question about, are these just
she was not given steroids that time. That I'm sure of. I checked all the prescriptions, only antibiotics given in March.
Okay. And she did show a response to them or recovered spontaneously.
Yes, she got better. She got better with the antibiotics in March.
Permission to speak?
Yes, please, Athol.
If we break this down, you have now 2 episodes of flares. We'll get on to what is driving them. But you have these 2 episodes of consolidation, and in those areas, you have worsening fibrosis in the background. And from the outset, the FVC was low. So we are actually looking at one of those processes. You suggested inflammatory myopathy. I would expand that slightly. One of those processes where you have rapid inflammatory signal with fibrosis. Now, there ain't too many infections I can think of that I would want to put into the picture as the primary driver, but certainly infection is a powerful cofactor, bringing out immune dysregulation if you've got an immune dysregulation problem. So maybe we should think of this as a more chronic process with acute flares, in which infection might come along and provoke more inflammatory disease. Now, if I was trying to make this TB, you would have to educate me, because you've got this major inflammation which regresses when you treat for bacterial infection, sits there for a while, comes back, and regresses again when you treat for infection again, although this time I think I got it right, you added steroid. It's very difficult, I think, to see this as an infection as the primary diagnosis. And you will have to lean on your Indian experience of TB to correct me on that. So what would we instead be dealing with? And the one that worries me is a form of vasculitis. Now, you've effectively excluded inflammatory myopathy. And although we classify vasculitides, actually a third of vasculitides don't read medical textbooks. The nodular change is intriguing. I'm trying to fit this in, but I wouldn't fit this into inflammatory myopathy very easily. This seems far too explosive to be a form of sarcoidosis. I mean, you would always have that in mind, wouldn't you, with the nodular element of this? You can't make this in hypersensitivity pneumonitis. But when I come to the end of this, it seems to me inflammation is driving fibrosis, and there's a labile inflammatory element. So I would have argued you might make a working diagnosis, but treating what you have in front of you, your regimen should certainly include anti-inflammatory treatment. And the thing about vasculitis is it promotes infection, and infection promotes vasculitic activity. So I suspect we might be in that sort of cycle here. And so the issue really is, should you be doing further tests to nail down a vasculitis? And if you can do it, obviously one would do it. But if you can't do it for one reason or another, and you've gone through urinary sediment and you've gone through the other things where you look for vasculitis, I would manage as for an aggressive vasculitis, I think, because I know that would cover the other inflammatory fibrotic pathways that you might wish to come up with. So you're going to have to tell me about whether I'm wrong about TB. I always, speaking to you, understand I've got to step backwards and hear what you say about TB. But if we take that out of the equation, that is how I would process this, I think.
Sure. So Athol, I did think of TB, but shadows have been resolving. Also, I was just pulling out her file again. In March, Murli was asking, there were all her cultures were negative. She was treated as CAP, and it was probably viral CAP.
Well, you must tell me
Community-acquired pneumonia. That's what the
if you take out the consolidation, the rest of it looks like a fibrosing NSIP.
right, right. Get your point.
Maybe TB causes fibrotic NSIP, but the fibrotic consequences of TB I've stumbled across haven't really looked like that.
No, not at all, not at all. In fact, when we thought, or when the chest physician treated her for the second time and thought it was cryptogenic organizing pneumonia, he started steroids and 24 milligrams of methylprednisolone. But that time, the sputum culture grew strep pneumonia and Klebsiella. At the time, in the November scan or the October scan.
Yeah, you've gone quiet, Sujit. I'm
Aparna
not sure
showed.
if you're still
But
speaking.
Sorry?
We lose you for 3 or 4 seconds at a time. What I'd say about this, if you want to create a further differential, the term OP-NSIP is appropriate. And some people divide NSIP into a subacute and chronic. That's a Japanese tendency. So consolidation like this can be, with fibrosis, you can be talking about idiopathic OP and SIP, or you might use the term fibrosing organizing pneumonia. What would be unusual, though, is to get regression of the consolidation in that setting using antibiotics. And that makes me think that infection might be a cofactor, but we don't see it as a cofactor in idiopathic OP and SIP, subacute in SIP. We do in vasculitis, and I believe we can do in inflammatory myopathy, but you've excluded that. So to me, all roads lead to a strong suspicion of a vasculitic process. And that's a situation where you can fool yourself. You're being Procrustean. You're creating a diagnosis in order to be secure about a label. And yet, the management of that does cover, I believe, the range of possibilities of what is happening here. So I come back to, should there be a biopsy procedure?
Right.
And I think with DLCO 47% and a 6-minute walk distance of 400 and something meters, sure, the desaturation is what it is. You'd really like to find a footprint of a vasculitis outside the lungs if you can, obviously. But that's really the question. Do you actually view this as one of these aggressive inflammation drives fibrosis related to immune dysregulation and don't call it more than that and manage it as that? Or do you take the step of trying to nail a vasculitis? And would you do that in a setting where the inflammatory bit has settled for the moment and what you've got looks like fibrotic NSIP? How much yield would a lung biopsy actually have in this setting?
So can I, give you another point of view? She's in hospital, away from whatever is triggering off her problem, gets better, goes home, remains well for some time, gets another episode, gets into hospital, again gets removed from whatever is triggering her problem, and gets better again. I mean, this is just to raise another point of view. I agree completely with Professor Wells that this is most probably an NSIP. I'd probably call it a cellular NSIP getting fibrotic. The lung functions are completely different from what you'd expect looking at her CT. Her latest CT, I assume the lung function done in December was timed along with the CT scan, which is looking better. But her FVC is still pretty poor. It's just 1.12. It's really bad. We should probably repeat that. I really think a biopsy is needed. The question is now, when she's looking better, do we do it, or do we wait for another exacerbation and do it at a time before she gets worse? Professor Wells, do you think it'll show changes now?
She's on 8 mg methylprednisolone. I thought this is the best time to do a biopsy. She's likely to refuse. If she refuses, Athol, would you agree with Murli that we just get her in and pulse her for 3 days?
Yes, I would agree with that. And I suspect there was always a lot more fibrosis there forming with low FVC. I don't see OP doing that without fibrosis to that extent on the first scan. I think it'd be very unusual to have an FVC as low as that in that setting. Murali, I thought about weird HP, and I can't really marry it up. You can get this acute HP. It's a rarer variant. It used to be called classical. You can get an NSIP lookalike in HP. That's also true. But to have the two together is not something I can remember seeing. So my instinct is not, I think, the bird positivity I would benignly ignore. It means her immune system, for whatever reason, recognizes a bird trigger, and maybe her immune system is simply hyped up. Now, the problem with the biopsy is that I don't think you can remove therapy and wait for another exacerbation, because the next one might evolve to lung injury, and I think that would be terribly risky. And I also distrust somewhat that you will get a clear answer in a treated patient in this setting when you've have effectively prevented the more diagnostic features being on a biopsy. Could be quite wrong about that, of course, but you're weighing up likelihoods. You are recognizing there's some additional risk to a biopsy. So it's one of those things where I suspect the patient won't like the idea of being the key person to decide. You really have to know what you're going to do before the conversation.
Sure. Sure.
But I mean, I think the first thing might be to look at some form of inflammation outside the lungs and urinary sediment, any other clue you might get. I didn't see whether you'd done the anchor stuff, by the way.
Negative.
He did.
Yeah, thanks. It was probably there and I failed to pick it up. So I think you might be stuck with a management that you had to institute. And firstly, what you've got left on the scan doesn't look like it's really too reversible, does it? So your methylpred idea at this stage, I'm not sure that you're using that in a way you would use it with an active de novo vasculitic process in the lungs. I think you might be settling on a form of maintenance therapy, but I guess that anything you can get back is valuable. The main thing is if you do go via methylpred, I wouldn't commit to long-term high-dose steroid here.
Sure.
And I would be settling into a drug like methotrexate or azathioprine. Mycophenolate doesn't have a great track record in vasculitic processes.
Right.
So I think I would be saying that you settle on a management as for a form of vasculitis. You believe this will cover alternative diagnostic labels that you don't have. And instinctively, one part of me says you've always got to have a biopsy in a situation like this. And I think on balance, I would do it with the misgivings that you have. Whether a cryobiopsy would really have enough yield, it's vasculitis that worries me most for cryobiopsy. But it would be a compromise at least if the patient wasn't prepared to have a VATS procedure. And I'm still a bit bothered that you've removed the inflammatory bit. You'll get fibrotic NSIP and you won't really answer the question. Cellular NSIP has always been more indolent when I've seen it. It hasn't been explosive like this. Now, this is a rare disorder, and maybe I've not seen the disease behavior to 2 standard deviations for cellular NSIP, so it's not out of the equation. That's all I can think to say.
No, it's very useful. Thank you so much. Asmita, you may want to get on to the next case. Thank you.
Just one point to add, and that's the autoimmune flavor comes in from what's happening to her son. So that's another support for you.
Yeah. That was also, she kept asking me, is it got anything to do with his illness? And then her son's excellent response to IVIG. And that's why we were thinking we may get something on the myositis blood.
Yeah. So Dr. Sajita is, I believe, Associate Professor in Kottayam Medical College, and she will be presenting this case. Sajita, over to you.
Hello, good evening. I hope I'm audible.
Yes.
Yes, okay. I'll proceed with the case. I'm presenting a case from Government Medical College, Kottayam. She's a 28-year-old female who was an HR manager in Kochi with a background hypothyroidism with a regular menstrual cycle with history of bilateral pneumothorax in 2014, which was treated with bilateral VATS pleurectomy with no details of further evaluation then, was symptomatically stable still then. When she had an air travel, she again developed episodes of chest pain and exertional dyspnea and then presented to us with complaints of shortness of breath 6 months. There is no history suggestive of any connective tissue disease, any of such history, and no history of exposure to any birds or pets or exposure history, and no history of similar pneumothoraces in the family. Her respiratory saturation was normal, no exercise-induced desaturation. The head-to-foot examination was normal, cardia was normal, ultrasound was normal, and fibrotic FOB was also normal. And her blood parameters all turned out to be normal. with a 1 plus nuclear homogeneous pattern in ANA immunofluorescence. The alpha-1 antitrypsin was normal, and the SPEP was also normal. The electrophoresis was also polyclonal gammopathy alone. ANA profile turned out to have a 1 plus rho 52 positivity. It was just 1 bar positive. Myositis panel turned out to be negative. Her FVC at the time, February 2023, is about 57%, and she had a DLC also done then, which was around to the tune of 48%, reduced then. But during the follow-up, when the PFT was repeated, her FVC actually improved to 66%. In between, she had a biopsy done and pneumothorax drained. This was the X-ray when she presented in 2023 to us. And she also had, we have, the CTs will be presented now.
Yeah, over to you, Aparna.
Yeah, you're able to see the CT, right?
Yes, yes.
Yeah, so there are two CTs actually, and this is in 2014, so 10 years ago. And that was the time when she had bilateral pneumothorax, some loculations on the left side. Bilateral ICD was also there, and multiple scattered cysts were there in both lungs, like this. One more here, one more here. And there were no nodules, and whatever kidneys we could see on this CT, there were no lesions in the kidneys, no lymphadenopathy, and pulmonary artery was normal. So main things we will want to consider in the young woman with cysts would be Lamb and Burt-Hog tube. So for Burt-Hog tube disease, you said there's no family history, and we are not seeing any renal lesions. Skin lesions also, you said you did not see any skin lesions. For Lamb also, there is no renal angiomyolipoma. Now, the next CT that is now.
Before you leave that, could I
Yes.
ask you a question? As you
Yes,
go
yes.
up and down, you see these very, very, very thick-walled appearances for what we're calling cysts. And I've certainly had a number of radiologists who've called those cavitating nodules. As you go up and down, some of the cysts aren't, but some of the cysts have this striking wall thickness, holes with very, very solid walls. Would you contemplate a cavitating nodule process resulting in cysts in those nodules that have had the cavitation and left a cyst behind? Because I would not expect to see that in lamb, I don't think. What's your
Yes.
view on that?
I did not actually see any like that, sir.
So
Maybe some of these, but there is a lot of atelectasis there because of the collapsed lung,
So
because of the pneumonia.
we're seeing chest drains, but I think
Yes.
in some other areas, you have that sense in one or two, but I think most of them are
Yes.
actually the
Yeah.
intercostal tubes, aren't they?
Yes, yes.
There were just one or two more central areas that disturbed me slightly, but I think that probably we can pass on from that. But
Yeah.
it really does look as if the chest drain is piercing the lung.
Yeah, it's somewhere inside the fissure.
Right, okay.
Yeah.
Okay.
So the next CT is from May 2024. So there's no pneumothorax now, and the cysts have increased in size and number. Multiple cysts are there, and now the cysts are having all these these oblong lenticular shape. They're having located in that paramediastinal location. Along the fissures, there are cysts, and there are, again, we're not really seeing any nodules. All of them are cysts, again having that lenticular shape along the fissures and subpleural and paramediastinal. So this description is looking more like the Burt-Hog tube description. Some of the cysts are little like confluent and having thin septations within also. Still on the whatever kidneys are covered, there are no lesions in the kidneys. So, I mean, I would go for think that it would be more towards the Berthold tube, despite the absent family history and no other features. Maybe gene testing, FLC and gene.
Okay. There were 3 CT, na? Do you have any more, Aparna?
One was just soon after this, in 2014
Okay.
itself. It was soon
With
after this.
YCD,
Yeah,
yeah, with
yeah.
ICD. Okay, okay. I'll just show the other reports. 1 second. Yeah, Sajita.
Yeah, actually, so these were the differential diagnoses we considered regarding considering her history, but her genomic study, but turned out to be negative. The clinical exome alone was done, but FLCN was covered in that. That was negative for any variant. We had a VATS, we proceeded with the VATS biopsy. She's a very young, pretty girl. She wanted to have a definite diagnosis, so we proceeded with the VATS biopsy, and over to the
Yeah, Ritu madam.
Yes, yeah, hi. So
Hi.
we have an adequate biopsy showing multiple cysts which are thin-walled, which are in the peribronchial area. And as has been described, the cystic areas are alternating with the parenchymal areas where there is, there is a good number of hemosiderin-laden macrophages which are present. Now, why is there so much of bleeding? To see that, I tried to zoom in and see the vessels. And the vessels have got, like in this image, which is here, just left to the bronchiole, which we can see, there is one vessel which can be seen, and that vessel is showing vascular hypertrophy, and it has got some perivascular edematous processes also going on in them. Now, in the second biopsy, which the first one, immediately the first one, uh, yes, this one. So this is the first one, and just next to the bronchiole, we can see the vessel, apart from the cyst, which are thin-walled and which are not associated with any UIP-like pattern. So there are cysts which are there. There is emphysematous change which is there in the alveolus. There are bronchiole which are normal, and peribronchiole, the vessel accompanying it is showing mild smooth muscular hypertrophy. In the next slide, which is there, if we can change, yes, in this slide, apart from all the previously mentioned changes, in the center there is formation of a lymphoid follicle also. And in the third slide, yeah, this is the lymphoid follicle. And in the next slide, which is there, if we go to the next slide, this is a area where it is the parenchymal changes are not so much, but if you see the pleura is thickened, go to the periphery, there's some pleural fibrosis which is going on in this entire biopsy which is there. So I'm seeing 3 or 4 changes: parenchyma, vessel, and the pleura. And we go to the next slide, please. Here again, a lot of emphysematous change, but look at the pleural thickening. The pleura which is there on the right side is nicely thickened and fibrotic. And next slide, please. This is something which is disturbing me, is the amount of hemosiderin-laden macrophages. If we're looking only for a pure cystic change, like say a lamb, we would see more of interstitial fibrosis and less of this kind of bleeding. So next slide again. If we have another one slide, yes. So again, this is showing on the right hand side the cystic change, and on the left hand side the alveolar spaces which are filled with blood and hemosiderin-laden macrophages. So the bleeding is not only occurring presently, but it is also considering amount of hemosiderin-laden macrophages. It's a kind of a repetitive and chronic bleed which is there with some amount of peribronchial fibrosis. Can we go to the next slide, please? Okay, so this is what we have. So a lot of changes happening. Cystic change definitely there, but a lot of changes in the vasculature and in the pleura. And that one lymphoid follicle. So my this thing would be more towards the CTD ILD if we could have some corresponding evidence.
Okay. So this is it, and this was the pathologist report from outside, and these are the questions, Sajita.
Yes, so she's a young lady who's actually very worried about her prognosis, and she would any other investigation to be done, and how frequently she needs to be followed up with any precautions to be taken for her, considering her cystic nature of the disease. The pleural thickening may be due to the pleurectomy bilaterally. It was done actually in 2014. Bilateral pleurectomy was done to prevent further, but she had minimal encysted pneumo when she had air travel.
Yeah, so Murlimon sir, you can take first and then we'll go to Professor Wells.
So I would first go for BHD because everything fits that. The absence of the follicle gene doesn't completely rule it out. There are some cases, I was just looking at it, where the follicle gene can be negative. If the pleural involvement is, satisfactorily explained by the previous pleurodesis that was done, then I'm not too worried about the pleural involvement. It's a little more difficult to explain that one area where there is a lymphoid follicle and the vessel involvement. So I think we should make a clear search for connective tissue disorder, of course. Dr. Sajida, what was the genetic test that was done? Was it specifically only for follicle gene, or did you ask for a variety of the cystic panel?
Actually, they did a clinical exon. We asked for tuberous sclerosis and Burt's specifically, and both were negative. And BAP came out as positive, but that was of insignificant significance, as they themselves mentioned. It was a clinical exon. The selected panel only was done, sir.
We've had a couple of cases, and I think Professor Wells brought this up for one of our cases where, and I think Dr. Bhavin also brought it up. We've seen a couple of cases of surfactant-related disease where infections trigger off this kind of cystic change, and every infection you tend to get more and more cystic change. It's typically a change that you see in children, but we have seen and we are hearing reports of more adult surfactant-related cystic lung disease. So if we really convincingly ruled out Burt's disease, then I think I would be inclined to investigate for CTD and also perhaps look for surfactant-related gene disorders.
So that panel has to be censored. Surfactant-related gene disorder.
Yeah, so first let's do the simple one, which is the connective tissue disorder workup.
The panel was done, only row 52 was positive. That is only a single bar, 1+.
Again, very non-specific.
Yeah, very non-specific. But actually, as Madam has explained about this hemocytin macrophages, there was one instance when she mentioned she had a mild hemoptysis, very, very mild. She said jet specs, but that was way back just after the pneumothorax. So we actually didn't consider it much significant, but it should be taken, I think.
I understand I'm supposed to speak next on this case.
We are waiting with bated breath, Professor Wells.
Well, I certainly wouldn't hold it here. So I'm not sure either what this is. David Hansel used to have a classification for cystic disease on CT, 2 classes, obvious or impossible. And this one is more impossible, but I do agree. Berthold-Dubé would have been appealing just on the scans. I became sidetracked by trying to find an inflammatory element, and unfortunately I looked at the intercostal drain and then looked elsewhere, but I think I talked myself into that. It's a shame we've got an explanation for the pleural thickening, because that really would have carried you there. And the trouble is we have straws in the wind here. So the row 52 in the general population is going to be non-specific. By contrast, if you've got a high pretest likelihood of a CTD, although that row 52 theta won't be decisive, it sort of would add support, but we're in the hinterland between. And again, I can't make anything of a single solitary lymphoid follicle. But the vessel involvement does bother me in all of this. That's the thing that bothers me. So I would, again, include a weird form of vasculitis driving some sort of cystic process. I can't really... I can't really nail an individual CTD that gives rise to this. You could play at rheumatoid nodules that have cavitated and left cysts behind, but I don't think it looks like this. So I think we're in great difficulties with this case. And I can only agree that chasing a CTD is going to be a logical approach, but what you do to manage this is actually very difficult.
Yes, thank you. That the management.
We should talk about management, but I'm hesitating to hear what Murali adds on the diagnosis of this. I think we've talked ourselves broadly into a tentative working diagnosis of a CTD process here, which may be a bit more likely than not, and I don't like the unclassifiable label. I think we do have to try to form something that we think is more likely than not and call it a working diagnosis. And we can talk about management, but I've got nothing more to say about diagnosis.
Interestingly, she's had virtually 10 years when she's not worsened very much. Between 2014, her first pneumothorax. Yes, the cysts have got larger,
Yes,
but
sir.
clinically, Dr. Sajid, has she got much worse in these 10 years?
Oh, actually, 10 years, she was not under any follow-up for any hospital. And 2022, when she had this air travel only, she had developed this. And after that only, she came and consulted us after about 6 or 7 months of that. But she gives a history of frequent respiratory infections, and we all advise her to get herself vaccinated. So that is settled now. But as such, now she's better after her this VATS biopsy and draining of pneumothorax. Now she's invariably better, but she's still worried because she's not on any drugs and management. We're just doing follow-up with CT. So she's really worried, and she's planning to get married, etc., and asking about the prognosis too. So how frequently do we have to repeat the ANA panel, the ANCA panel? That all we would like to know.
What is the inflammatory markers, CRP-SR?
CRP-SR were all normal, sir.
Normal.
You know, the one thing that drives us away from Berthold-Dubé with a negative test, in my view, is the vascular changes. And if you didn't have that, I would be awfully inclined to have that as my top diagnosis on other grounds. If you think about the fact that this has been indolent in the background. So what I don't know is whether on Medline you can get, rarely in Berthold-Dubé, the sort of vascular abnormalities we've seen on the scan. Because if that does exist on Medline, then that would carry me more towards that diagnosis, I think, and then you would actually be monitoring the situation from here. So I don't know the answer to that. If anyone can tell us whether you can see the sort of vascular changes at biopsy if you biopsy Berthold-Dubé.
So, will a lip biopsy give any clues for salivary gland, any inflammation?
Well, you'd be saying
You're muted.
you'd be saying the form of LIP, I think you would be chasing with that, wouldn't you? And could it
Yes.
really be LIP, which has plainly been very active a long time ago? You're looking in something that doesn't change much, and yet you've got an active vascular process going on. The trouble is, whatever you choose as a diagnosis, there are things that don't fit. And that means whatever the explanation, however unlikely it is, well, actually, it's going to be an unlikely explanation. So if we run through the checklist, it's Berthold-Dubé with a negative follicular gene test. It's a weird form of CTD. A vasculitic issue, but again, you've got a decade of cysts slowly enlarging, but you've got that vascular signal. That's third on my list, I think. Now, for the first two, I'm not sure that you've got an approach other than monitoring. Do you really want to subject her to immunosuppression based on what is seen on a biopsy in limited areas? Do you know that you need to do that? And if she's stable, are you calling that a success, or are you calling that treatment wasn't necessary anyway, or you're giving her side effects? So I really struggle with introducing an active therapy at this moment.
Yeah, I would agree, Professor Wells. With one single lymphoid follicle, do we have the courage to immunosuppress her? Yeah. So I would probably, Dr. Sajida, if it's not, if cost is not an issue, I'd go to whole exome sequencing or whole genome sequencing and reassess.
Okay, sir. Okay, sir. So do we have to repeat the ANA panel or have CTD follow-up?
I think it's not needed.
Okay.
No,
One point I would like to add, sir, because Professor Atul Wells told that if somebody can search about the pathology of Barthold-Dubé, which I just did on the very good review article, in which one thing which is mentioned is a thickened pleura, then the other is pulmonary edema or angiogenic factors which will increase vascular permeability, which might explain your alveolar hemosiderophages, and also even pathology also other than that lymphoid follicle goes in favor of Barthold-Dubé. That's what the pathology says from the online review article.
Thank you.
well, that's very helpful because it leaves Berthold-Dubé top of my list.
Yep.
Now that we have a pathway headline search for things about the histology of Berthold-Dubé that one doesn't have in one's head. So that's very helpful.
Yeah.
Thank you.
I think that's it, and we will move on to the third and fourth case, which is being presented by me. Thank you, Sajita, for.
Thank you for that discussion. It was wonderful.
I'll just move on to case 3. So she is I'm sorry, yeah. So she is a 41-year-old lady who is an assistant professor by occupation, and her husband is a doctor. And they came here. They are settled in Muscat. They are basically Malayali who came here because for her checkup. She is hypothyroid and on treatment for last 15 years. She had history of multiple small joint pain for last 1 week. In January, she developed 1 week joint pain with dry cough and recurrence of dry cough. Because of dry cough, they went to a doctor and she was found to have some problem in her lung. The doctor didn't do biopsy, but because she was exposed to pigeons where she was staying in the flat in Muscat, she was initiated on short course of steroids. And then when she came to that particular doctor at that time was 68% on room air saturation, but otherwise she was okay. That time also the workup was taken, which was all negative. This is our workup in Amrita, and ANA profile was negative. ANA profile was negative, but ANA immunofluorescence was 3+ positive dense speckled, and ESR and CRP are okay. ACE level was also normal. Myositis panel, as Mithun always says, that this is not significant. But Mithun, how do you explain 3+ speckled with profile negative? I should ignore, huh? That also I should ignore.
Na3+, you see the pattern. It's a dense fine speckle pattern. It's also known as DFS70 pattern, usually seen in benign conditions.
Sure.
Then it's not significant.
Sure. And her pulmonary function test, when she came to me, this is from Amrita. So it was fairly okay, like 98% FVC with 105% FEV1, DLC of 683, AC of 63. She didn't desaturate and she was perfectly fine when she came to me. In between, there was a history that she came here in July also. So the problem happened in March, and March to July, she was given a short course of steroids. So the next time when she came to Kerala was in July, where somewhere else. And that CT scan was taken, and then because that CT was okay, she stopped steroids, and then she came here because her symptoms restarted. So this is the history, and I believe Aparna will show the CT scans.
Yes. So for this patient, we have 3 CTs. So this is 1st of April, then in July, and this is in December, 16th of December. So the first time in April, what we are seeing is multifocal, small, patchy areas of ground glass opacities and faint consolidations, which are bronchocentric as well as peripheral subpleural kind of appearance, and some lower lobe predominance is there. So I was thinking whether it could be like an OP or NSIP OP overlap type of pattern at this moment. And then the next CT that we have is in August. So this is, I think, the first time when she presented. And then Dr. Asmita said when she came back in August, sorry, this is July. July, when she came back, she was better. And the CT is also much better. But there is some faint kind of diffuse ground glass diffusely in the lungs. But it's no longer having that patchy appearance, and it has definitely most of these things have improved now. But I feel some background changes are still there, but there's no fibrosis. And then the subsequent CT, which is in December, has again developed the same findings that were there in April, almost similar to that. So some areas have become even more denser now on the present. So this same area, if we see, it's more areas are involved. So I'm thinking more like an OP or NSIP OP overlap like pattern. There's no significant adenopathy and pulmonary artery is not dilated.
This pattern doesn't match in hypersensitivity pneumonitis, right, Aparna?
No, doesn't really look like hypersensitivity.
There are no nodules in the July, no? The July CT scan doesn't look like centrilobular nodules or something.
There is some faint ground glass, but not specifically a centrilobular pattern. I think it's like more diffuse and ill-defined.
Sure. Okay.
There's still no fibrosis.
Yep. So what happened is when she came here in July, she was just finishing her course of steroids. So she went to another, not to me, but she went to another hospital, and that doctor felt that she's perfectly fine and the steroids were stopped. Now she's telling that they have changed multiple places of their house, but wherever they go, pigeons are there. So there was significant doubt about whether it is hypersensitivity pneumonitis or not. And the husband specifically asked me whether we should send her precipitin profile for hypersensitivity or not, for which I told usually it doesn't help, but I would take opinion from the panel. So any point of sending hypersensitivity profile right now? Is there was a bronchoscopy which was taken earlier, and because it was a steroid responsive disease, and because as she told it is NSIP OP pattern which we can easily make out on the CT scan, what additional benefit by biopsy I will gain. So I was not considering biopsy, but if you people feel biopsy is important, I might consider. And there was time when there was a recovery. So should I challenge? I have just started her on steroids because she has to travel back. And I have told that additional medicines are required or not. I will discuss with you people and then decide. So these were my questions. And Murli sir.
Was her saturation 68% at the beginning?
When she went there.
When she was there.
Yeah.
And then it completely settled down. It was completely normal when she saw you. She didn't
She is
desaturate on the 6-minute walk. She's done very well.
Perfectly fine. Yeah.
So to me, it doesn't really look like, CT-wise, as Dr. Parna says, doesn't look like an HP. Rather looks like an OP/NSIP pattern. But I would not hesitate to send a precipitin panel. At least you've got something that you can offer her. A biopsy is where I would probably be inclined if she's willing. But I also wanted to check, you said she's an assistant prof, Dr. Asmita. What is she an assistant prof of? Does
think
she have any exposure at work?
no exposure. She told she is a lecturer. I specifically asked chemistry or something, and then she told some subject, but usually classroom work. Nothing,
Okay.
no exposure to labs, nothing.
Okay, okay. I was just a little curious. We know that in the Middle East, they spend their lives in air-conditioned circumstances. So apart from pigeons, and generally these places are sealed, I would also keep fungal infections in mind, and which is why I think still doing a HP panel is worthwhile. If we have completely ruled out connective tissue disorder, and I'm sure Dr. Mithun will say, don't send another test. What you've done is enough. The only thing that intrigues me is what happened in January, where she had these small joint pains, though it lasted a very short time. OP, especially the way it's recurred, got better, steroid responsive, quick response. I would still go for OP as my first choice. The problem is, are we dealing with a CTD associated OP, or is it a cryptogenic organizing pneumonia? That's the main thing that comes to mind.
I will add on to the things which you said, sir. So in March, she told that she was diagnosed as some viral pneumonia and was treated. And there was in between CT scan of May and then July. So what happened is in March, she was diagnosed and discharged with 68. She was admitted in ICU and all. She was discharged. Then in May, they did CT scan. I don't know why. And that May CT scan was bad. So was started on steroids. And from May to July, she was on steroids. And July, when she came here, the CT scan was showing resolution. So they stopped. Actually, yeah, the doctor told that March, he was expecting it was a viral pneumonia and everything will disappear. Maybe COVID or something, that's what they told. And then because it didn't go, they started steroids. And then she came back in July and July was okay. So stop steroids. So within, I believe it was a very short 2 or 3 months course of steroids. And then it came back, and as Aparna said that there was no fibrosis, so I believe that it is steroid responsive. Why? That is why I didn't consider a biopsy. Anyway, Professor Wells, what do you say?
I'm afraid this is another case where whatever explanation it is an unlikely explanation. And so I've got three possibilities, and then you can say the fourth possibility has got to be there. It's something I haven't thought of. So let's just run through it. So HP actually has quite a spectrum of abnormalities. You can have BIP, NSIP, UIP. You've got a potential trigger, and there are reports of outdoors exposures to birds, and then you've got the air conditioning issue as well. Generally, I don't like precipitants much because if you've got a clear exposure, then they're just telling you that the patient has a clear exposure. And if you've got zero exposure, I never know what to make of them. But when it's a situation that there's a potential trigger, which you think might be implausible, the positive precipitants establish that at least to the patient's immune system, the trigger is plausible. So I agree, it would be good to do that. And so one of my three is atypical HP. I'm going to put bottom CTD, and I don't think there's enough likelihood that you can turn around and say the non-specific ANA in the general population might be more relevant here based on pre-serology likelihoods. I don't think it sounds like people think that CTD is likely enough at the end of this. So my other one has to be what we saw in COVID, but what has always been believed as long as it's been thought about. And that is that viruses can trigger autoimmune processes. And there are quite a few reviews before COVID came along to establish that. You've got a bad enough viral pneumonia to give you a saturation of 68% on Rumir. That seems to coincide with the start of that. A viral pneumonitis appears to have been diagnosed, and I don't think it has to be COVID. It's just we understand more about viruses triggering post-viral issues with immune dysregulation, and that is the top of my list. that this is some sort of viral trigger driving a form of immune dysregulation. And we can call that form of immune dysregulation a form of cryptogenic organizing pneumonia if we want to give it a label. So that's my favored distillation. My second favorite is that it's atypical HP, and I don't buy the CTD. And you'll just get sidetracked by that serology because the likelihood of CTD before you look at the serology isn't high enough.
Okay, the question is, because husband is a doctor, he was worried about the steroid considering her age and all. Should I add MMF or something right away? Or should I give a proper course of steroid, repeat CT scan, wait? Because this is like a recurring. She responded to steroids, stopped steroids, came back, but however, the duration was very short. So for how long I should wait before adding, or should I add right away?
It's always tricky, isn't it? Murali, do you want to comment first?
Okay, the first thing I would suggest, because HP is in the mix and atypical HP, is can she move away from that place, stay in a place where there is no exposure at all?
They changed 3 houses. That
No,
is
not in the Middle East. Move away to India and stay there for 3 months and see if there's a significant improvement. Because to my mind, removing the source would be the best way of finding out if there is a problem and safer than steroids. If they can't do that, then I would be very tempted to give her a course of steroids and see what happens. And as we taper, assess what her lung function is like and see what's happening there.
okay.
So expanding on that, and it makes a lot of sense. And indeed, a viral trigger might promote the sort of immune dysregulation that brings out an HP subsequently. So it is complex. But the first question is whether she still needs steroid, and the lung function shows normal spirometric values at the top of the normal range. The DLCO is still in the normal range. The KCO at 63% interested me, and then I decided let's not be too cute about that and overinterpret that. If it was a touch lower, I would be putting a bit of weighting on that there's a potential vascular issue. But I just think if you've got inflammatory infiltration, you get DLCO reduction without necessarily getting a fibrotic lung volume reduction effect. So we can ignore that. So I would say that you need to find out if you still need the steroid. And it would be ideal to do that after she's moved away from an environment which may be driving an HP process. If it's post-viral, a la COVID, a sort of long viral effect, you again would hope that the heat might go out of that with time. I certainly don't like the idea of just leaving her on steroid. I think that's the worst possible option, and that you've either got to go for a second-line agent or you've got to establish the minimum dose she now requires before you make a judgment. I favor the second approach, especially with the idea that she gets out of the environment, and not commit to a long-term decision yet on long-term therapy.
Okay.
Murali?
Yeah, I completely agree. And the advantage you have is she's got a doctor at home who can monitor her carefully. So that.
Yeah, physician. Yeah, he's physician. Sure. Good evening, Katrina. How are you? Happy New Year.
Happy New Year to all of you.
Yeah, I'll move on to the last case and not last case, second last case from my side. This is clear cut, I believe. This is one 66 years old lady with type 2 diabetes, hypertension, DLP, and coronary artery disease. She was diagnosed as interstitial lung disease in 2022 and was initiated on Perfenix 200 milligram twice daily along with LABA ICS inhaler, and she was okay with that for last 2 years. However, her problem started worsening when she came to me, when she decided to come to me. So she had presented with recurrent dry cough, throat irritation, intermittent episodes of dyspnea, and recurrent use of nebulization, but no relief. When she came to me, her saturation was 90% and other things were normal. She had bilateral Velcro crepitations. I will just show ANA profile, which was SCL70 1 plus, row 52 1 plus. And ANA surprisingly was negative. That is like usually my workup includes myositis profile and I sent that also. And this is what we got. Mithun, any sense out of this? So many things positive, but ANA negative.
ANA you can consider it as negative because ANA immunofluorescence, this is all very mild positive things. No, it may not be significant. And here also multiple antibodies are positive. Usually classically these antibodies are usually mutually exclusive. That means if PL7 is positive, OJ should be negative, like that.
Okay.
But PMSCL74 are all myocytic associated antibodies, can be positive along with other antibodies. If clinical symptoms are there, we can consider this PMSCL as significant. Otherwise, difficult to say. Nothing.
No, she doesn't have, she didn't have any exposure history. She doesn't have any CTD, this Sigmeta history. Also in her examination, her pulmonary function test was showing desaturation to 80% from 95%. She could walk only 180 meters. And her FVC was 75 and FEV1 was 83. I will just show the CT scan. I'll request Aparna to show the CT scan.
Yes. So we have only one CT for this patient, which is of 20th of December of this year. So before starting the pirfenidone, we don't have that CT and we don't know whether she's progressing. So on this CT, what we are seeing is a lot of fibrosis with lot of traction bronchiectasis, which is involving upper lobes as well as lower lobes and centrally as well as peripherally. All areas are involved. And there are these lobular and some irregular areas of air trapping. Some scattered cysts are there, few areas of air trapping, some areas of normal density also. So this is the involvement. The extreme lung bases are, in fact, almost like spared. So, diffuse involvement of lungs, both centrally and peripherally, and upper lobes and lower lobes with fibrosis in the form of traction bronchiectasis, no honeycombing, and few cysts and some areas of lobular air trapping. Other findings are she has some small nodes. So some paratracheal nodes are like around 15 millimeters and pulmonary artery is dilated 35 millimeters. No RARV dilatation. And a small hiatus hernia is there. Esophagus also is mildly dilated, but I think it could just be age-related dilatation also. She has some calcified granulomas in the spleen. So these are the main findings that we are seeing. So the lung pattern is basically like definitely a fibrosing type of ILD. And because of this diffuse involvement, both central and upper lobe, lower lobe involvement, no honeycombing and the extreme bases being spared and with some areas of air trapping. I'm thinking more in terms of a fibrotic hypersensitivity pneumonitis pattern.
Okay.
Sorry, could I ask if the patient had any features, clinical features of autoimmune disease?
No.
Arthralgias, nothing.
Nothing. She's an old lady with lots of limitations. She cannot do her own work at home at present because of her breathing difficulty, mainly dyspnea rather than any other problem. And they got panic because she was doing quite well with the current treatment, which she was started for 2 years, and suddenly it worsened. So they thought that, okay, they can come to me and see whether it works. So because she came first only, then I just increased from 200 BD to 600 TID, which I might gradually increase further because of her age. I was worried. So my question is it IPF or CTD ILD? Because I also saw that there was no subpleural basal honeycombing or anything. So my diagnosis of UIP, which was the diagnosis from our radiologist, was not matching. So that is why I have put the case for discussion, because it was not classical UIP on the CT scan. And is this perfenidone enough, or any more treatment can be offered?
Can I ask you also something? Did she have any nail capillaroscopy or exclusion of scleroderma, or do we have any kind of amyopathic myositis as end stage disorder? Because we have the antibodies. I don't know if how we have to.
Myositis panel was negative. She doesn't have clinical features of CTD, and I didn't do nail capillaroscopy. Mithun, should I do right now?
Amyopathetic myositis, let's say, without any features of systemic diseases,
But profile
but only
negative, no?
no. It is not the classical appearance, but what
Yeah,
I
I got it.
see in the lungs is a fibrotic lung disease, and
Hmm.
if it is, let's say, if it is a progressive disease, which is a CTD background, I'm not sure that pirfenidone would be enough. Or maybe if we can change to nintedanib as progressive fibrotic disorder at this stage. But I don't know if maybe Athol does not agree. I don't know
I
if
don't.
this panel, yes, if this panel, how this panel should be considered. Of course, I agree that it is not a UIP, UIP IPF pattern. That's why I'm considering a progressive fibrotic disease in a
Yeah.
lady, and I'm trying to find some autoimmune features, maybe, but not in this.
Yeah.
Okay.
Mithun, usually amyopathic also, CD, this particular clinically amyopathic dermatomyositis also will have positive serology, right?
Amyopathic, clinically, you have the skin manifestations usually.
Yes.
Yeah.
That,
She
So if
doesn't
that is,
have.
then antibodies can be positive, may or may not be positive.
Always not be
Uh,
positive. Sure, sure, sure.
yes, but the problem
Look,
is that sometimes
CT
if it is a fibrotic stage, we miss the stage where we have the clinical manifestations of the mechanic hands, etc. So that's why I'm telling that maybe now the features that we see in the CT are like terminal disease, progressive disease. So
Mhm.
maybe the initial phase in a woman, non-smoker, as far as I understood, with this profile, for sure I wouldn't consider IPF as a, but that's why I'm telling that if I consider this in the profile of this woman, I would treat her with nintedanib as progressive disease, and maybe some kind of immunulation like MMF or something, in order to combine and to have also this approach covered treatment wise. Because I think we lost the initial phase of the disease where it was more florid or maybe with some features of CTD. But I would like Athol, what he thinks.
I'm way away from CTD here. So firstly,
Why?
I take completely the comment on the non-specific serology. You would have to have a high pre-serology likelihood to make anything of that. And
Yes, but she didn't do. She didn't do in the past.
sorry, can I speak?
Yeah, yes, of course.
Secondly, I do see when there's immune upregulation for any reason and not a CTD, you sometimes get these multiple mild antibody titers, but they're not part of the disease process. When you look at the CT, you've got a triple density sign. You've got cysts that are well recognized in HP. The fibrotic change is more mid to upper zone, and rather than being out on the edge of the lung, it actually, I thought, was probably greatest more centrally in the mid to upper zone. So mid to upper zone fibrosis,
Yes.
extensive ground glass, triple density, cysts, no convincing CTD features. And so for me, fibrotic HP is clearly the top diagnosis. Now, what you say about management, you can apply to this setting. I don't think I've ever seen a scleroderma lung case that looks like this on a scan. By the time you put all those features together, triple density, cysts, distribution of fibrosis, and
Maybe the air trapping
having
too.
triple density, that's what I'm talking about, yes. So black lung, normal lung, increased density. So, I mean, you can't say that there mightn't be a hidden CTD, that it's resulted in immune upregulation, and therefore you're more likely to get HP. You can
So
create,
what would you do?
create a castle in the air, but I think the management here should be as for fibrotic HP, and I agree strongly this is not IPF. Thoroughly.
So you would change to nintedanib with a little bit of MMF or not?
Well, it's tricky because I do think this is a case where you probably have both pro-inflammatory and pro-fibrotic pathway.
Yes, that's why.
And so it would be logical. I mean, I think we can debate the diagnosis, but I think the broad principles here that the major crime is to miss an opportunity
Indeed.
would drive me to cover both pathways.
I agree.
Please, sir, anything you would like to add? Or?
No, I completely agree. This is not IPF, definitely. The only other thing is her ESR is so high. 80,
I agree.
Yeah. So I don't
what
think
did you say? What did you say?
So
ESR.
Erythrocyte sedimentation rate was 89. So clearly there's some kind of inflammatory process going on. So it's certainly worth adding on, immunomodulator.
Can I ask if we have ANCA or we have a urine sediment in this lady?
No, I didn't send it. I'll send it. I'll do
Just
that.
to have a look. Yes.
Sure. Okay. Management, I will go by what you are saying, that maybe I'll switch over to nintedanib and see. And slowly.
I'm not sure about that. Why should we change? She's tolerated pirfenidone well. Why do you want to risk changing her?
She's old, she's old. That's
should
why.
Come to 1800 and see how she tolerates that.
I'll do that. Okay. You are presenting. Lakshmi is presenting, right, sir?
Yes, Lakshmi is presenting.
Yeah, over to you, Lakshmi, please.
Yes, ma'am. Thank you, ma'am. Good evening, everyone. Today, the case for discussion from our side is a 29-year-old female from Bangalore who is an HR professional with nil comorbidities, presented with complaints of fever and cough with expectoration since 2 weeks, chest pain since 1 day. She doesn't have any significant past history, any history related suggestive of any connective tissue disorder or any significant respiratory illnesses in the past. No significant family history. She presented with complaints of high-grade fever with chills since 2 weeks, which subsides on tab paracetamol, associated with cough, which was initially dry, later become productive with mucoid yellowish expectoration. Her has a history of recent history of travel to Bihar. Her symptoms started the day next day she reached there. In Bihar, she stayed for almost 12 days in a resort in where they uses chlorpyrifos 20% as an insecticide spray within the room. So in from Bihar, she had consulted physician and taken antibiotics, tab cefixime and azithromycin for 5 days, but her symptoms were not subsiding. She came back to Bangalore. Again, she was spiking fever and the symptoms were persisting. So she again consulted doctor, then started on Taxim O and tab azithromycin. Then they did COVID and H1N1, which was negative. Other infective parameters were raised, but she continued with antibiotic. She came to our emergency because of sudden onset left-sided chest pain, which was sharp, no, not radiating, which aggravates on deep inspiration. So on arrival, her vitals were stable except for temperature. It was 100 degree Fahrenheit. She was maintaining saturation. Respiratory system examination was also bilateral air entry was there. Bronchial breath sounds were there on left interscapular area. Initial lab were showing elevated in infective parameters. Total count of 13,000, which was neutrophil predominant. CRP was 53. ESR was 59. Other routine blood works were within normal limit. Chest X-ray was showing left-sided haziness, left mid-zone haziness. So we admitted her and started on empirical antibiotics, ceftriaxone and doxycycline. CT chest was done, which was shared with madam.
Yeah.
Yeah. So there are two CTs. Basically, first one was a CT, and after that there is a PET CT that has been done. So this is on the 18th of December. So on this CT, what we are seeing is multifocal, small, patchy focal areas of consolidation, which are central as well as peripheral, subpleural also in distribution, slightly more on the left side. And some involvement of the bases also, and minimal bilateral pleural effusions were also there. Then this is 6 days later is the PET CT that has been done. So we can see that all the findings have significantly worsened. So this was the previous area of consolidation. Now much bigger areas of large area of consolidation has developed in the same area with some ground glass around it. So all findings are a little more in the left lung, but definitely right lung also has some small patch areas of consolidation. And the effusions are there. Minimal bilateral pleural effusions are there. The consolidations itself, when we see, trying to see if there's any like necrotic like areas. So some areas do look of slightly low density. And there is lymphadenopathy also, but nodes are also not particularly looking necrotic. So on the PET, all these areas are avid. The lung consolidations are also avid, as well as the lymph nodes are avid. And there is some uptake in the spleen also. Spleen is not enlarged, and there are no lesions in the spleen on the CT. But normally the spleen should not be more avid than the liver. So there is definitely some avidity in the spleen also. In the abdomen, there is no significant lymphadenopathy and some other incidental.
Okay.
So
we have lost your sound, sadly.
Aparna, you became muted? Okay.
Sorry, I just got a cough.
Yeah.
Just
Okay.
recovering. Yeah. So because of this rapid worsening, it's looking very much like an infection, is what I would think.
Okay. Yeah, you recover. I can understand. So mostly infection is what Aparna is thinking, and considering the lymph node and other things. So we will just move on to what is there, Lakshmi. Yeah.
Yes, ma'am. As she was not improving and her infective parameters were worsening, total count raised up to 18, CRP went up to 197, but PCT was still 0.2. We escalated antibiotic to injection piptas and clarithromycin. On further workup, her LFT also got deranged. All tropical fever workup were negative. Sputum, she was getting the sputum, so sputum culture also done. It was normal flora. Blood culture was no growth. And because of non-resolving, we pneumonia kind of picture, we evaluated with ANA. ANA was histones 1+, and myositis profile, it was PM-SCL 75 borderline and MI 2 alpha borderline. But as she didn't had any clinical feature, we it was from our rheumatology team also opined us it is not so significant. So we proceeded with the PET CT to rule out any other foci of infection also, which we have seen. After the PET CT, we did a UST guided biopsy from the lesion in the lung, which was slides all shared with Ritu madam. From our pathology team, the opinion was acute fibrinous and organizing pneumonia. And the tissue culture has grown Bacillus megaterium, but in the report it was like probable contaminant.
Ritu madam, I have no slides, so I can't share. Anything you would like to add from the diagnosis?
So I had the slides sent to me, but I don't know how to share them. But those slides are showing organizing pneumonia definitely. But in addition to that, I thought I saw a necrotizing granuloma. There was one area in the center where there was some area of necrosis, and there were few well-defined epithelioid cell macrophages. But the necrosis was not basophilic; it was eosinophilic in nature. So I would like to ask if the as AFB culture gene expert has been done for this patient.
ZN stain was negative, ma'am. Culture we haven't.
Tissue gene expert was also negative.
Negative.
Okay.
And it has been sent for culture. The biopsy specimen has been sent for mycobacterial culture. Okay, we were convinced we were dealing with an infection, but it just took too long to settle. There was a lot of pressure. You know, Dr. Lakshmi spoke about her being at a resort in Bihar. She'd actually gone for her wedding. And all this transpired during her wedding. So we're talking about a young lady who's just coming back from her wedding, not settling down, huge pressure from the family, which kind of pushed us. So the initial report from our pathologist was also, they felt this was all infective. And we said, can it be something else? Because we were considering the possibility of an organizing pneumonia. So then they looked at that and then came back with this diagnosis of an acute fibrinous organizing pneumonia. We looked at the literature looking at Bacillus megaterium. It's usually a very benign organism and seems to only be picked up incidentally. There are a few reports of infections, especially in someone who's immunosuppressed. So what we did was we changed her. So we reviewed the literature on acute fibrinous organizing pneumonia, and it looks pretty bad. They talk about a 50 to 60% mortality rate. So we were really worried. So she was started on steroids. Seeing the Bacillus megaterium, we escalated her antibiotics to meropenem and what else did we put her on, Lakshmi? I forget. We put her on 2 antibiotics. Following the steroids and the change in antibiotics, she had a remarkable improvement, but we're still confused.
Clindamycin.
Yeah. So she's currently on a tapering course of prednisolone along with meropenem and clindamycin. And I must confess, we still don't know whether you're dealing with an AFOP or it's all just infection. The thing is, Bacillus megaterium is the only thing we cultured. And there is some report that they have used this. It's basically used in the production of proteins at bioreactors, but has also been found to encapsulate pesticides, insecticides, in order to prolong their action. So it's a very strange kind of bug, large bug, and there are very few reports on its clinical significance. So we were hoping that we could get some experience from, Professor Wells.
I think the single most helpful thing I can do here. So the thing called AFOP was discussed extensively in 2013 and again in a process that's going on at the moment, which will amount to a reclassification document. But I'll just refer to 2013 because I'm giving nothing away, but I can tell you nothing much has changed. AFOP is not a diagnosis, it's a histologic pattern. And actually, it's part of the spectrum of lung injury. And just as in more traditional lung injury, you sometimes get a larger element of subacute injury, which is OP, basically, it's subacute injury. You do have these patients who have the pattern called AFOP, sometimes with Highland bulls. and they can respond nicely. I think the bad outcomes are more about the larger subgroup of patients that have diffuse lung injury with an AFOC pattern. And I think, fingers crossed, this might be a form of lung injury triggered in some way by an infection where you've stepped in and dealt with it. And that is how I would tend to see it. I would walk away from reaching for a diagnosis of AFOC because it was debated hotly in 2013. There are two histologic patterns that didn't make it. ASIF was closer, airway-centered interstitial fibrosis, and I personally think there's a case for a diagnosis for that entity. AFOP, not so. And the cases I've seen, they've varied from what looks like a nastier variant of organizing pneumonia with lung injury to lung injury that has a more prominent element of organizing pneumonia. But the key bit, it's part of the spectrum of lung injury. And I think maybe that is how this is best perceived, and then maybe infection is a trigger of that. And it may have a bad outcome if you take aboard the patients with far more extensive involvement, but it's got a better outcome than AIP and other forms of diffuse lung injury, and you appear to be on the right road.
Thank you. Would you agree with the steroids? Because we were very...
Yeah, I would, because you are stepping in to treat something that might otherwise have exploded further. I do agree strongly with how you managed it, especially with the histologic support. I mean, there may well have been infection there driving this, and I don't think that stops you saying that you had to treat this pattern in its own right as a form of lung injury with actually quite a reasonable likelihood of reversibility and a better outcome, and much more so than idiopathic ARDS, for example, what we call AIP, and certainly much more than the acute exacerbations that are lung injuries and fibrotic lung disease. I absolutely agree with the management.
How is she doing, sir? How is she doing?
She's remarkably better. We've discharged her. She'll be coming back next week for a review.
I did a quick search on whether that bacteria can cause granuloma. So bacteria megatherium is a kind of organism which causes granulomatous inflammation. So maybe you have a right catch, but who diagnosed it? Microbiology, or you said myofire panel or something?
No, this was microbiology. They do a MALDI-TOF, and that gave us the diagnosis.
Interesting.
Dr. Mola, I'm just wondering actually whether there's any underlying immunodeficiency here actually,
Yeah,
I'm pretty concerned about possible kind of CVID or something like that, because they're the people who develop these kind of abnormal
Yes, it
immune
was
response.
mentioned. It was mentioned that way.
Yeah, I'm just wondering whether we should screen for that as well.
Sure.
Immunoglobulins
But
and
she was
all.
a perfectly healthy young lady. I mean, she looked good when she came in, and everything has exploded over a couple of weeks. No previous infections, no recurrent infections, and so on.
I don't know only one, sir, but I would like to give you one or two examples of experience which I have got. So I have got a young patients coming to ICU with very bad pneumonia, and that particular moment, if I am sending immunoglobulins significantly low, and that was a one single episode, because I kept them for follow-up, and I'm checking after 2 months and 3 months and every time, because I don't start directly immunoglobulin replacement immediately. And I had seen that out of some 10 patients, if I have done with severe pneumonia as she developed and no response, ideally her immunoglobulin should have been high. But if you find low and we correct, that is a single correction which corrects everything. But next time she doesn't need, or my patient, very young patient, without further requiring dose of immunoglobulin. So I don't know why it happens and how it happens, but there is a tremendous low immune response in some patients in spite of having severe pneumonia. So
I do have the same experience actually. I mean, they
yeah.
have more specific immune deficiencies for specific bacteria. And
Yes.
so therefore, I do think, I mean, there may be a place, but
We'll certainly work her up when she recovers, and look for a long-term solution for her if there is a problem.
It's a very attractive hypothesis, actually, because you would be saying there is a specific immune deficiency there. Now, what happens then? You've got a continued antigen exposure. You activate alternative, more aggressive secondary pathways. And I could see how that could then promote a form of lung injury. So there's a great logic to it. We can't call upon Katerina because apparently she's had to go and fetch her daughter from school. So I don't know if anyone else here wants to comment, but
No. I think we are too late today. It is already 6:41 and oh my God. But it was a good discussion and very interesting cases.
fabulous cases, I have to say.
Thank you so much, everyone. Yeah.
Thank you. And see you
Thank you.
next week.
Thank you.
17th January will be the next date. Professor Wells.
Well, I will be in mid-air on my way to New Zealand, so I will
Sure.
have to excuse me. I
Sure.
don't think in even Qatar Airways that it will be possible to join online.
No problem. Thank you.
Thank you.
Have a great day. Bye. Manish, we are ending the meeting.
We are offline.